So many clients that I see in clinic with shoulder pain, specifically shoulder impingement, have struggled to find a long-term fix despite seeing many different therapists, trying all kinds of different treatments and remedial exercise. And it's no coincidence that many of these same therapists that those clients have seen have failed to look at the shoulder girdle, specifically the scapulothoracic joint. Anatomy time. The arm is connected to the body via the scapula, and the shoulder joint where the arm meets the scapula is called the glenohumeral joint. The glenohumeral joint is the ball and socket that most people know as the shoulder joint, which consists of the ball or the head of the humerus, and the socket, which is the glenoid, a projection of the scapula. There's a group of muscles that bridge the gap between the two. They connect the arm to the scapula, called the rotator cuff group, and you've probably heard of these. You may even have been given banded exercises to strengthen them, which is fantastic. But if we're strengthening this group of muscles with a still dysfunctional scapular position, then we possibly need to be doing more. So time to look further down the chain. What connects the scapula to the body? Well, this is what we call the scapulothoracic joint, because it's the scapula moving on the ribcage, and there's a muscle sandwiched in between the two, a big muscle that's often forgotten about called serratus anterior. And that is my reason for making this video today. If you can begin to understand serratus anterior, what it does, how to strengthen it, how to get it working functionally, then that will enable you to provide a long-term fix for your client's shoulder pain. Try this. Contract your serratus anterior. It's difficult. Most people don't even know that they've got this muscle, never mind where it is or how to actually use it. And if this muscle isn't strong and we can't recruit it in shoulder movements, then it's not going to be providing the stable foundation that we need for the arm to move from. Weakness in serratus anterior can lead to a protracted or winged scapula. You know the one where the shoulders start to roll forward as we slowly return back to that fetal position through a life of desk-bound posture and doom scrolling. This can lead to tightness in the pecs, it can lead to inhibition in the rhomboids and the mid-traps, and it can also restrict the thoracic spine through lack of mobility, leading to a hunch. If you're a therapist, then it's likely that you see this kind of posture a lot, and it may even be the case that you're doing things to address tightness in the pecs, internally rotated shoulders, and restriction through the thoracic spine, which is great. But in most cases, if you're not doing anything to address the weakness and instability in serratus anterior, then you'll be fighting a losing battle against gravity, lifestyle, and poor postural choices. Try the scapular wall press to assess the patient's scapular retraction and protraction. What we're really interested in here is the patient's ability to combine scapular protraction with depression, which is difficult. You can palpate the client's serratus anterior here to aid in the sensory feedback loop and recruitment of the muscle. The ability to contract and recruit serratus anterior and being able to combine the active elements of scapular protraction with depression should then go on to form the foundation for any upper body resistance exercises, pushes or pulls that the patient does in their rehab or in the gym or in life in general. And of course, there are many other options to strengthen serratus anterior. Some of my favorites include the lying scapular press with a dumbbell, an uppercut press with a dumbbell, and progressions of the scapular wall press onto a raised surface and then down to the floor. Depending on the client's ability, see what fits them best and what works for them and for you.